Good afternoon, everyone. Yes, I'm not a medical doctor. I'm actually just a computer scientist doing a lot of research on health data. And even if you might think that well, I'm not treating any patient itself, how does it affect you? Then I can say that actually the impact that research does may affect every one of us even more, because the guidelines are made based on that, and the local organization of the healthcare is also often based on the scientific results. I did my PhD more than 5 years ago on personalized medicine, meaning that I worked with genomic data. But after that, I turned towards common clinical data, meaning the electronic health records, because it's much easier. And I must say to you that I'm pretty sure that today we are here talking about sharing clinical data and make some, common APIs. In genomics data, all these discussions are ahead. In 10 or 20 years, I'm pretty sure that we're having the same mistakes, same issues at that time. But anyways, today I'm going to talk about the clinical data and doing science on top of that. Actually, the whole work I'm presenting here is not my personal achievements, but the results of the whole research team we have at the University of Tartu. And to kick off my talk, every physician knows how he or she treats his patients. But what we often don't know is, for example, how many patients have some certain disease in Estonia, or in which clinical setting the diagnosis is given or recorded. Is it by a GP or specialists, or is it made in the intensive care unit? Another set of questions are related to treatment. Let's say, how some certain disease or condition is usually treated in Estonia, or how it is compared to other countries and so forth. So many questions, quite general questions, I would say, but often we don't know what is the answer. And in medicine, nowadays the medicine is evidence-based medicine. We do need evidence to both treat the patients and also to make some sort of decisions to make the healthcare system better. And here is one example. We were part of the study of improving the clinical care pathway of heart failure patients. Until the project started last year, there was no clear understanding of how these heart failure patients are treated in Estonia and how the disease is diagnosed as well. And it was a very short project. Actually, it lasted about 3 or 4 months. And first time in Estonia, we figured out, we analyzed the electronic health records and found out that actually 1/3 of the primary diagnoses are given in ICU. And it's a pity, because it's the most expensive place to have the diagnosis like this. And another issue is that actually most of these patients actually had a contact with the GP within 6 prior months, which raises several questions why these GPs were not putting or giving more attention, putting more attention to the patients and so forth. And what is more, it turns out that this heart failure diagnosis should be followed by 2 important tests. One of these is echocardiography, and another one is so-called marker pro-BNP. But it turns out that half of the patients had no indicated tests conducted. So it raises several questions. But this is just one example what we did together with a wide set of experts in the field, and I'm returning to that example later on in my presentation. So, in order to make anything better, for instance, to make the treatment of these heart failure patients better in Estonia, we do need evidence. And there are like two options, I would say two most general options to get the evidence. First of all is the gold standard prospective blinded randomized clinical trials to prove the causality and so forth. But the problem is that they are very expensive. They are we can't analyze all kinds of questions through clinical trials. And the second option is so-called retrospective studies on real-world data. And the real-world data is exactly the data that is collected. Here I have the example as well. All kind of clinical information that is recorded during common clinical practice. For instance, data from hospital information systems, insurance claims, prescriptions, case summaries, and so forth. All kind of clinical data about the patients. And the primary use is both the data producer and also the data user, meaning that if we go to the doctor whatever he does to us, but anyways, he or she records some kind of information about us, and then later on he can reuse the data for the same patient, or another doctor can see what this doctor wrote about myself, for instance. And now the secondary use is only is using that data for some sort of new purpose. For instance, to conduct some analysis on top of that data, do some research, or get some results to make some sort of healthcare decisions. And the real-world data has several pros and cons. First of all, of course, the data exists already, which is a very good thing. In clinical trials, it's very expensive to collect the data, and it's considered to better reflect the real life, because the clinical trials are conducted in a very strict conditions and environment. But usually, what I just learned yesterday from the data, that we have patients that have 15 chronic diseases at the same time. And it's really a challenging environment to actually study anything. But exactly from the real-world data, this is what we see. And important thing is also to have longer time period of the patients in real-world data. And even in Estonia, if we think that the first, let's say, clinical electronic health records come from 2012, it's now, how many? 13 years, yeah. I can't calculate on stage. Anyways, it's already, no, 13, it's more. Anyways, it's quite a lot of long time period of the patients. Of course, in science, we do need even more. It would be nice to have a whole lifetime data of the patients. But even if we have the narrow data, it's good enough. It's almost good enough already to start thinking about. For instance, if we are interested in some disease and want to calculate the 10 years mortality, then you understand that we are actually looking of the patients who have had the diagnosis more than 10 years ago. So another good thing is that we can really study a lot of questions regarding incidence, prevalence, risk factors, and so forth. So wide area of problems we can potentially solve. But there are problems as well. First of all, the data has been collected for different purpose than we use it currently. So the data quality varies a lot. It's usually in a wrong format, meaning that we do need a pre-processing of the data to answer our questions. Data is spread across several data sets. We do need to link the data using different classifiers, using different versions of the standards, and so forth and so forth. But here are some examples of Estonian datasets. For instance, here at TEHIK, the health information system is managed. On the left, you see prescriptions database, insurance claims from the Health Insurance Fund. On the right, we see some registry data. And also, in addition to health data, we have many other datasets available, which in principle could be linked because all Estonians have a personal ID, and all data elements in all these registries actually have data about the people together with the personal ID, which means that in principle, at least, it is possible to link the data from several data sources. And I have an example here why this is important, because the same heart failure study, we had to answer, very first question actually was how many patients there are who, first of all, have heart failure diagnosis. And to answer that question, we had to go to the data set of insurance claims, but it was not enough because there was another criteria. How many of these patients have no prior diagnosis nor prescription in 4 years? So we had to link another data set, which is a prescriptions data set, to check whether this condition is satisfied or not. And we had another criteria, and whose diagnostic tests refer to a heart failure. There are 2 tests, as I mentioned. Sorry, I mentioned the first one, but there is another one. But the results of these tests are not recorded in any of these data sets above, so we have to return to the health information system, which had these measurements written in the lab measurements or into the clinical notes. And this illustrates how it is actually very much needed to link different data sets, even to answer a quite simple question. Okay, I've been talking a lot about the introduction, why we need all these kind of things, but now how a study on real-world data really looks like. This is the kind of a timeline of a typical study and how the legislation pretty much sees it. First of all, it starts from the study hypothesis, then the protocol is written, approval got from the ethics committee, the data is extracted from the different data sets, then the data is pre-processed, data analysis conducted, finally some results are published, and if the study ends, usually the researchers have to delete the data they used. But the problem is that all the data sets are different because they are coming from the different different hospitals work differently. Even they have different purposes. The registry data, the prescriptions data, the format of the data is different in these systems. And when the researcher gets the data, the first thing is to do some pre-processing to transform the data in a more usable format for them, and then can do a master data analysis who takes into account all the differences between the data sets here. And this part can be very time-consuming and very expensive as well. And I strongly believe that many studies have not been conducted because of that, because of no resources to do that. And the pity is that usually at the end of the study, I mentioned not only the data is sent to bin, but also this software made here is not very well usable for other kinds of studies. Because the data we got was had some very specific structure for some reason, or from our scientific question, and also the software code answered one specific question. And it was clear that we can't continue like this very long. And this was the reason why we do need a common data model. And we do need to convert the original data sets to some sort of common format. And hopefully to make it as an automated pipeline, meaning that we are not doing it as a handwork all the time. And we had two options here. First option is to invent our own data model. We selected that as a preferred option first. And then after a couple of years, we discovered that it was not the right choice, because you can start inventing a bicycle yourself, but it turns out that you don't have resources to make all these mistakes by your own. So let's use some existing model. And luckily, at that time, we were working on that. So-called OMOP common data model was released or made public, let's say, and the project that developed the model was Observational Medical Outcomes Partnership, and from the first letters, actually, the data model has got his name. And very briefly, what is this about? The common data model is basically a model that is made of two parts. First part is the data, and it's a very simple, fixed relational database structure. It has less than 400 data columns, and as I mentioned, they are very well fixed. You can't add columns, you can take them away. And it doesn't even have identifiable data of the patients, meaning that, addresses, phone numbers, whatever. It's specifically designed for the data analysis. It doesn't care so much about one particular patient. And the main components of each event is only three main components: pseudonym of the patient, event concept, and the date. And the concept, it's important part. The concept is recorded by using standard vocabularies. And all these vocabularies are strictly set for the OMOP common model. And I think this is one of the key things that has made the OMOP so successful. It has fixed vocabularies. You have to use any of these vocabularies to record the data. But it has several vocabularies. For instance, SNOMED, RX norm, but it also supports ICD-10 and ATC through mappings, meaning that you can record the data in ICD-10, but then you have the mapping to corresponding SNOMED term. And the open community is it's also open. Everyone can join. There is no leading organization of that. The community name is called Odyssey. And in the introduction, you mentioned that I'm the lead of the Odyssey Estonia. Basically, I'm trying to just coordinate the activities in Estonia. What kind of opportunities it brings? The first thing is that every data owner still has to transform their data to the OMOP common data model. No one else can do that, because the data owner knows the data best, and they know the background, the policies behind it. Anyways, every data owner has to transform the data into the same common data format. But as a result, you'll get very similar sockets here to do the rest. And the good thing is that there are tens or even hundreds of software packages that can work on top of any kind of this OMOP common data model because of this common socket here. And now, how a study in the OMOP dataset network looks like is that still every data partner in the study is responsible for their data. They are still keeping their data into private environments. And when a study is launched, basically the study protocol is written. The study protocol is basically the same thing as software package. And the same, the software package is then sent to data partners, and every data partner can decide whether he wants to join the study or not. But if he does, then he just runs the study package, gets some statistical results. The statistics are then combined. The statistics doesn't contain any individual level data. They are combined by the study coordinator. Hopefully, the results are published, and not only the paper out of this, but also the software of the study, meaning that anyone in the world can basically, who has their data in OMOP format, can also use the same study package to, let's say, validate the results. And this is what I call like high quality evidence, or really very open, very transparent, and as I mentioned, there are like many packages already available. Here you can see some examples of standard OMOP packages. If you are interested in studying disease prevalences, you basically can just download some packages and run them right away. And it has really increased the speed of conducting studies. Because often you don't have to invent anything on your own. If you have, let's say, if you have your OMOP dataset in your house, or if you are just a researcher wanting to do a network study, you basically take software package, set some parameters, send it to the data partners, and wait for the results, basically. And this is what European Medicine Agency is also utilizing. There's a Darwin network, which is a very good example of OMOP datasets. And the EMA had a problem that they had to conduct some field studies to make drug-related regulations. And all these studies took a lot of time. And to overcome this problem, they launched Darwin Network, and last year they conducted more than 10 studies in that network, but they hope to conduct 100 studies this year, 2 studies a week, to get some information about the drug utilization and safety and so forth. It's really, it wouldn't be possible without the OMOP network having already all the OMOP datasets available. Let me check, not much time. Okay, very shortly. If in traditional studies, the cohorts are usually considered as a set of patients, then in OMOP work, the cohorts are more like events. If this is the timeline of one particular patient, then the patient can belong to different cohorts for a limited period of time. So you can think of this as a condition or a disease or something like that. And many studies actually in OMOP network often focus on finding some sequences between the cohorts or finding overlaps between the cohorts. And this is one of the examples we had in Estonia. We studied female patients in some specific having some specific conditions, and we defined different cohorts there. Sorry, it's in Estonia, but basically you can see a lot of like criterions for the people for one cohort, and then there is another cohort, and we were interested how many patients there are who are having this condition and having another condition within an observation window of 12 months. Okay, important thing is that usually this part of defining the cohorts is the most time-consuming part, traditionally, I mean. How it usually has happened so far is that some sort of clinicians come together, define their patient groups, and then they apply for ethics approval, they get it, then the data analyst comes in, makes a long query by knowing all the data sets, makes a query, gets some results, and the clinicians are not happy with the results and start redefining the cohorts and so forth. It's usually has taken months, if not years, I would say. But alternative way, and how it's usually done in OMOP communities, is so-called study-a-thons, meaning that participants from the medical side, from the IT side, from the epidemiology side come together to one room for a day or 2 or 3. And when clinicians start defining, let's say, some conditions, then immediately they got the result from the data owners, how many patients like this we are, what are the reasons why this definition doesn't work, should we improve the definition or something like that. So it has proven to help to get very fast results of any questions we have. And this is the example. I was also participating in a second so-called study-a-thon in Barcelona. We studied rheumatoid arthritis, and you'll see a lot of people, you know, scientists, doctors, data partners, and so forth, all working together for a common goal. Yes, we are like traveling and spending, let's say, a week somewhere, but it's still much more efficient than, you know, spending 2 years and getting nothing out of these. So, as all the previous lecturers already have mentioned, it's very much about the collaborations. We can't work in silos, meaning that the doctors and the data scientists and the statisticians and the epidemiologists have to work together for a common goal. It's for our own interest and for the interest of the patients as well to jump over all these hurdles, I would say. And here I have few examples of these study-a-thons we have been trying to make in Estonia as well. The same heart failure team here working together. And this guy here actually said that, the doctor said that, yes, it's a pity that I've been working on this disease for 30 years already. But this is the first time I really see the numbers of Estonia, which I believe it's a good sign that we are doing the right thing. So another study for studying epilepsy, and recently we started to write down some sort of questions the doctors need to answer about the cardiology as well. I'll jump over these. There are many data sets available in OMOP format also, and also in Estonia we have several scientific data sets for studying different diseases and conditions, and all of these link different kinds of data because, you know, for different diseases, different kind of information is important. And for Estonian community, we also made an article about all the opportunities in OMOP for in Estonian main medical journal. And my last slide is, I've been talking about the evidence. Definitely medicine and healthcare needs more evidence for treatment, for making right decisions. I can say that the number of studies on real-world data is increasing very rapidly. And for this kind of studies, I would say the OMOP is the de facto standard for the secondary retrospective studies. But of course, in order to keep the pace, we have to be very fast. We have to be efficient and automate things to be able to join all these international projects. Because if we are slow here, you know, no one cares about small Estonian data at all. And it is a problem for our patients as well. Thank you.
Thank you, Sulev. You're actually so punctual that we have no time for questions.